So, good afternoon, Dr. Maha Hussain. Thank you for accepting your invitation.
Thank you very much, and shukran jazilan.
Marhaban. So, you need no introduction, actually. So, I try to summarize as best as I can your biography in short, but
Sure.
still, I'm compelled to read through your achievements. So you're a professor of medicine in Division of Hematology Oncology, Department of Medicine, and you are a leader of Geo-Oncology program at Robert Lurie Comprehensive Cancer Center at Northwestern University, Feinberg School of Medicine. You received your medical degree from Baghdad University College of Medicine, and you performed your residency and fellowship at Wayne State University. You are a practicing oncologist, internationally renowned expert and clinical researcher in genitourinary oncology, particularly prostate and bladder cancer. And you are focusing on development of new therapeutics. You are contributed to several clinical trials and significantly impacted the standard of care of cancer patients. You trained many fellows and residents and young faculty. Some of them have chosen academic career in geo-oncology, and you have 275 scholarly article and book chapter to your credit. You have been invited to lecture in the United States and throughout the world. You have received so many honors and awards. I will mention just two because there are several of them.
Thank you.
In 2017, you named Kathleen O'Connor the exceptional woman in medicine. And in 2015, one of the Oncolife giant of cancer care. Maha Hussain, welcome to Bridge in Science. Thanks for accepting our invitation, and I appreciate it very much.
Thank you very much.
I learned also that both your parents are scientists and all your siblings are doctors. So maybe science and medicine is running into the family.
It does run in the family. Actually, I have also 3 uncles who are also physicians, yes.
So family, medicine is a passion.
Medicine is a passion in the family, yes.
Right. So we'll go down directly to the recent study you conducted. The olaparib was approved by FDA in the second quarter of this year, and based on a study, a very interesting study you conducted with several other investigators, and it was about olaparib in metastatic cancer, prostate cancer that became resistant to castration. What was the motivation? What was the rationale of this study? Why you choose to do it in prostate cancer in particular?
Sure. Well, my interest in evaluating the role of PARP inhibitors and targeted therapy in prostate cancer goes a long time ago. In fact, I began working probably about 10 years ago on clinical trial PARP and also different other pathways and specifically alkylator agents. And then was part of the Stand Up to Cancer Dream Team effort. And just for the audience, the Stand Up to Cancer is an initiative that is funded by different foundations and private entities. It's a very competitive application, and then they periodically put in requests for applications, and it just so happened that at that time it was specifically for prostate cancer. So I was part of the team that led this initiative, and that study was primarily designed to look at the molecular landscape or genomic landscape of prostate cancer. And what we ran several projects under that umbrella, but including patients who came in with frontline castration-resistant disease. Everybody had to go through a biopsy of a metastatic site so that it's better to inform, as to what is the landscape of the cancer there. And the bottom line is this, is that and I'm happy to share the references also with your audience. But the bottom line was that prostate cancer actually, over 90% of those tumors had potentially clinically actionable molecular alterations. Of those, actually, over 20% were basically mutations or alterations or aberrations in the sort of DNA repair pathway, BRCA1, BRCA2, ATM, and others. At the same time, there was a clinical trial that was being conducted in the UK with looking at olaparib in all comers, but it was in patients who have been previously treated. And that trial was also part of the Stand Up to Cancer effort, where the tissue from the patients from that trial was analyzed. And interestingly, and this was published in New England, first publication actually came in New England Journal of Medicine with Dr. Matteo and colleagues, and including Dr. De Bono, where they actually demonstrated that the patients who responded, the vast majority of them actually had DNA repair defect tumors, mutations there. And so that kind of prompted, again, the totality of the science, the biology, and this emerging data led to the design of the PROfound trial. And PROfound trial was really one of the first ever biomarker pre-selected. And we really wanted it to be that way because we wanted to better personalize care for patients, especially when you're really using a targeted agent. And so, so basically the trial was designed, a randomized trial, in order to make sure that we're really not compromising people's outcomes, patients' outcomes. We elected to do it in second line. So patients could have seen abiraterone or enzalutamide. And since this is an international trial, there are different countries that have different other agents on top of the ABI and the ENZA. Certainly in the US, patients would have seen chemotherapy, radium, different other treatments. And so all of these treatments were allowed, but the critical part was that they had to have progressed on a abiraterone or enzalutamide. And as long as they had the qualifying mutation, so everybody had to submit tissue. The tissue could have been from the primary or fresh biopsy, or if the patient had archival tissue from prior biopsies or prostatectomy, then the tissue was sequenced through a companion diagnostic assay that was foundation, that was part of the trial. And if they had the qualifying mutations, then the patients were assigned to a cohort that's applicable to them. So at the time when we designed the trial, and as you know, as a medical oncologist will know, that the kind of what we consider canonical pathways when it comes to the DNA repair pathway has been generally the BRCA1, BRCA2, and potentially ATM. And this is based on work again in breast and ovarian cancer. And of course, there was a whole list of other potential pathways that contribute to it, but there was not enough knowledge as to whether they will respond to a PARP inhibitor. And so we created two cohorts. One was the primary cohort, which is BRCA1, 2, ATM, and the other one was the other genes in there. Exactly. And all patients basically were treated in a similar manner. They were stratified by whether they had seen taxane or not, because that's critically the backbone of treatment in pretty much all countries in the world for this disease. And they were stratified 2 to 1 to get olaparib or physician choice ABI or ENZA.
They are regardless, they are received taxane before the ABI or ENZA, or the reverse.
Well,
ABI, ENZA, and then taxane.
Taxane, yeah, that's exactly, yes. The bottom line was the absolute line in the sand, as we say, was the fact that they had to have been exposed to ABI or ENZA. Failed. That's exactly, yeah. But they could have had other treatments. As you can imagine, by the time the study was activated, a lot of patients who were progressing have already been through different type of other treatments, because depending on where they are and which country and what drugs are approved and things like that, many of the patients have seen other treatments also.
So the result, what was the result? Which
the bottom line was
responded well?
the bottom line is that as I mentioned, when we designed the trial, we opted to make it as a clinically relevant endpoint being progression-free survival. So in the US, the FDA has actually probably, I think, the first drug in prostate cancer to get approved in frontline castration-resistant disease based on progression-free survival was abiraterone.
Yeah.
So second line was overall survival, but front line was that. And then, of course, overall survival came afterwards. So the design was actually to look at progression-free survival because we felt that this is meaningful for the patients. And then obviously overall survival was another endpoint. And the primary endpoint was actually in the primary cohort of BRCA1, 2, or ATM. And so at the end of the day, basically, the olaparib resulted in significant improvement in progression-free survival. Exactly, over almost doubling of the progression-free survival. And the curves, and I would encourage the audience to look at the publication, the curves pretty much separated very early.
Yes.
Yeah. And then the progression-free survival was actually not based on the treating physician, but rather independent review, because the whole idea was to make sure there's no bias in it. And then one of the secondary endpoints was radiographic progression-free survival in the overall population, and that basically was still there.
And regarding the other mutation, there was no such good response.
So actually, the benefit when it comes to radiographic progression-free survival was not as big in the second set.
BRCA1, BRCA2.
There was, aside from BRCA1, 2, and ATM, the others, there was a benefit, but it wasn't, the magnitude was not the same. Because of the design of the study, and because, as you know, the reason we had all of these mutations allowed is because some of them have low numbers. So there's no way you're going to have a trial that's going to look at it. Exactly. So you have to look at the kind of the big picture of it. And so the benefit was there. And interestingly, the FDA, in fact, approved the panel that we have included, except for one particular gene, which I'm not sure that it's really that relevant. In fact, if anything, I have to say when it was included originally, it was because at the time there was a suggestion that there may be, potential, that it may be actually PARP in nature, so to speak. But then more emerging data suggested that it's probably not something that is actually relevant from the pathway for DNA repair. So it was removed from there. So the FDA approval came in across the board for all of the 14 of the 15 genes that we included.
Did you make sure before selecting the patient and assigning each one to different groups that BRCA1 and BRCA2 ATM are pure BRCA1, BRCA2 ATM?
Well, so these
there
would
is
have
no minimum, no other mutation associated with them in this group that
actually,
might interact with the...
They were, so the way the panel works, you could have had other mutations, but if it was determined that the BRCA1, BRCA2 is the primary the dominant, then that would have been assigned to the primary.
To BRCA1, BRCA2, So the overall, there was a positive free overall survival and progression-free survival. There was no crossover between the two.
No, so crossover was allowed. So the progression-free survival was the primary endpoint. So when patients came off protocol, those who were on the on the ABI or abiraterone, prednisone, or enzalutamide were allowed to cross over. And so we captured all that data. And then obviously we then reported, which was fascinating, that despite the crossover, there was improvement in the overall survival. So when you look at the cohort A, still the primary cohort, there was actually a significant improvement in overall survival. Not just statistically significant, but I would say also clinically significant. Little over 4 months difference in, about 4 months difference in the median survival. And so I think with something like this, clearly I do think that there is enough benefit that one cannot be questioning the benefits in there. So the median, in fact, I'm pulling a slide here, the median overall survival for olaparib was 19 months, and this is a heavily pretreated patient population, 19.1 versus 14.7. And actually, when you adjust for crossover, the curves actually even further separate. Yeah. Now, the benefit in the setting of the other arm in overall survival was not statistically significant. Exactly. So there was a difference, somewhat probably about a couple of months difference, but that difference, 2.5 months difference, but that difference was not statistically significant. And I think part of the problem, of course, also is that the fact that that population is not huge. And so if you remember the days when actually mitoxantrone was approved, US, okay, or even taxotere over mitoxantrone, the magnitude was small, but then you had 1,000-patient trial, so it was powered. So the point here, I think, is this: is the FDA did see the benefit in the metastases-free, in the progression-free survival, and therefore basically approved the drug in the overall cohort. Yeah, one of the analyses that I want to refer your audience to, which was in the publication of the overall survival data that came out in New England in September, we actually wanted to look at, does it really make a difference what the patient has seen before? Does chemo impact? Remember, the patients were stratified by chemo. And what was fascinating is that for, let's say, the BRCA1, BRCA2, the benefit existed still before or after chemo, but it appeared to be bigger before chemo. With CDK12, actually, there was not much benefit before chemo. After chemo, and the bulk of the benefit was before. Fascinating, however, was the ATM story. The ATM, it seemed like you get much more benefit, after chemo, but not before chemo. So there are, subtleties that I think are very critical for the audience to, to look into. And while these are not powered, so any of these subgroup analyses are not powered, but I do think they will provide potentially interesting information, for the treating physicians. Yeah.
There is another PARP inhibitor that was approved as well, but based on phase 2 study.
Correct. Right. Yes.
Yeah.
Yes. Yeah.
It was just based on response.
Yeah, it was response and also radiographic progression-free survival, but it was not a randomized trial.
Yeah.
But there were really very nice responses, and it was also in the second line, so the patients have seen prior treatment. It wasn't what they call an accelerated approval.
Fast track.
So they fast track, exactly, and the definitive trial, I believe, is still ongoing. So I am anticipating.
There is a phase 2 going on now.
Phase 3 going on.
Triton 3.
Triton, yes.
Okay, it's great. Any major side effect with this PARP inhibitor?
Well, so I think there is no treatment, obviously, that has no side effects. The biggest issue that we've seen, exactly, and even placebo, as you know, but definitely, I would say myelosuppression, primarily anemia. Yeah, and as you know, prostate cancer patients predominantly have bony metastases. And so the marrow is already
suppressed,
damaged. Exactly, suppressed. Plus, these patients have seen multiple lines of therapy. So chemotherapy and other drugs. And so the combination of the treatment, the cancer, and all of that. However, I do think that overall, the treatment was well tolerated. And one thing I would encourage your audience to look at, actually, is the patient characteristics. There were patients in their late 80s, including, patients who were like 91 years old. So, so to have patients that old and
extreme
able to
age.
tolerate. Exactly,
It's good.
Yeah. What is the average age in Morocco of prostate cancer?
Prostate cancer is around 65, 70. That's the average.
Yeah. So as you know, a lot of these patients get diagnosed, they go through different treatments.
Unfortunately,
later,
we see patients a little bit late at the metastatic stage. Maybe 50% are seen at that stage. So people
Well,
are
I
consulted
think
early.
exactly. I can imagine why that might be, but I think, anyhow. But as I said, the treatment was overall well tolerated. The safety signal was no different than what was seen in other diseases like ovarian, pancreas, and breast cancer.
There was some GI tract toxicities as well.
Yeah, but they were mild.
Minor.
Yeah. The most common high-grade event was really the anemia.
And none of them required to stop the treatment.
There was very few stoppage,
Few.
and and we provide the information in the manuscript. Yes.
So just to go back to this genetic alteration, who should be screened for that?
Well, I think the guidelines keep shifting. So I would refer the audience to a lovely paper that just published in JCO. And this is from the, I'm going to call it the Philadelphia Consortium. But basically, and I'm more than happy to provide you some slides to share with the audience also.
So great.
But basically, I would say the recommendations are, generally speaking, men who have a family history. Okay, so that would be definitely there. And then
family history is
of cancer.
The word one, the broad one. I mean, from family, from mother's side,
family member, mother, father, cousin, brother. So family
first
history
degree
of cancer, first or second, or second generation. That would be one thing. The other one is patients who present with very aggressive early disease. I think, somebody who's 50 years old and have already metastatic disease, that's not the norm.
Yeah,
exactly.
Very aggressive.
Very aggressive disease. So that would be required. And clearly the assays have to be approved by your health, your health ministry or whatever organization you have in Morocco in terms of approving it. There are assays approved in the US, and basically what we do is this: we have genetics counselors. So these are people who actually specialize in, I can order the test, that's not a big deal, but counseling is very important. And so basically they would counsel the patient, permission is taken, samples are submitted for, usually blood or a buccal swab, depending on what the assay is.
This is
and then
for,
looking for the genetics.
Yeah, genetics. Just to making the difference between somatic and germline.
Well, no, this is for germline.
Germline,
yes.
Somatic is usually done on the biopsy.
Correct, on the tissue. So that's exactly it. Yeah. So basically, either a blood test or a, the one in Vita that we use is a blood test, and so that's what they sent for it.
Swab.
Yeah, and basically there are certain panel that has specific genes that have been determined as being, potentially associated with familiar history cancer, and it's FDA approved. And so basically that's the assay that is used. And we also talk about genetics counseling also, because first the patient has to understand the implications there. And what I tell my patients actually, and I would certainly strongly recommend it, this is just a test that we have today based on what we know. A lot of these patients come back with these tests negative, right? And yet there are patients who have strong family history or other relatives with cancer, or for no good reason they developed. My youngest patient with prostate cancer, 37 years old. Why would a 37-year-old get cancer? And so what I tell patients is this: if they feel comfortable, obviously privacy is important, but if they feel comfortable, they are to counsel their blood relatives regarding early detection. So for women would be breast cancer, ovarian cancer, and for men would be prostate cancer early detection, and definitely for both genders would be pancreatic cancer, because as you know, there is an association between pancreas, ovary, breast, and prostate cancer.
So once a patient is positive, he will be referred to a genetic counselor.
Yeah, I generally refer them up front so that they can work with them. But yes, once you counsel, once you determine you're going to do the test, if it's positive or if it's negative, I generally do refer them. And I definitely also counsel them myself that, irrespective of what the results are, especially if it's negative, that doesn't mean your relatives are at no risk. So if you are comfortable, have them at least go through, through early detection.
So
mammograms, whatever, PSA testing and things like that.
Whose responsibility to break the news to the family if someone is positive?
It's the patient.
Yeah, it's patient. The doctors should not be involved. Is this?
No. I think there's again. I would say Zain, it's all to do with the culture of the country.
Sure.
In the U.S., there is a lot of boundaries,
ethical issues
privacy,
that cannot be
ethical issues and privacies. And I would say that should be true everywhere.
Sure.
This is a private issue. The patient should break it. And what I told them basically is this: is if your family members would like to get counseling, then certainly their primary care doctor can refer them to our counselors, because I shouldn't be, getting into their private, health records and things like that.
What about the cost of this drug now in the US?
It's expensive.
How expensive is expensive?
I can't tell you, but all I would tell you is this: I don't know what olaparib costs, but I would imagine it's quite expensive. But just to give you a feel. I can look it up, but the problem is with us, there is the cost, but there is what insurance will cover.
Insurance will pay, right?
And then there's a copay factor. So, and for some insurances, it may pay a portion, but then more after a certain amount of time and stuff like that. That's why I don't guess on it. But these drugs in the US are not cheap. Yes.
Not sure.
But neither is abiraterone, nor is enzalutamide, nor is apalutamide. And this has been a topic of issue for cost that we've been pushing very hard for. But unfortunately, it hasn't been, cost is not something.
Easier.
Yeah. This is at the government level. This is above my pay grade.
It's politics.
Yes. Yeah.
So your study and the other study have ushered the new era in the genetic-based targeted medicine and opened up the way to so wide variety of questions. So how this therapy will fit into the armamentarium of prostate cancer treatment? Will it just stay in the metastatic prostate cancer, or will move earlier in the evolution of the disease, as we do with the Enzo and Abi, by putting them before the metastatic stage? Do you think
obviously,
PARP will move to that stage one day?
I think it will. I think, honestly, Zain, all of these are fantastic questions. And this is what I actually, if I'm making a formal presentation, that's the kind of stuff I put into my slides, where we talk about what is the next step. I think the next step is figuring out where does it fits within either rucaparib or olaparib in the spectrum of things. And the reason, as I said, we did the analyses to look at pre-chemo, post-chemo, was it precisely that, is you want to get a better feel for where the fit is. The other part is pre-Abi Enza or after Abi or after Enza. How does that work? And then clearly, I would say the ultimate goal is to conquer the cancer. And as you know, and I always mention this, the model in oncology, the model for cure is testis cancer, right? I mean, absolutely. You get metastatic disease and we cure it. But even testis cancer, as sensitive as it is to chemotherapy, you still have to give 3 drugs. Or 2 to 3 drugs to treat it. Exactly. And so I do think combination therapy is going to be the future.
So because you cannot sequence the therapies one after the other and waiting for one to fail in order to introduce the other.
Exactly. And what you want to do is to figure out what are the synergistic or more than additive combinations to include, which is actually some of the questions that are being asked right now. So there was, as I mentioned, preclinical data literally from 10 years ago easily, where it demonstrated that co-targeting the PARP pathway and androgen receptor could give you better results, in terms of
even in the patient without mutation, probably.
Well, the point of it, the preclinical data was actually it was not cell line, it was generic cell lines was not really pre-selected for mutations. The whole background is sort of like you give the AR target, you give hormone treatment, then that might create sort of susceptibility And then you're creating sort of artificial, I call it synthetic lethality, by adding the PARP inhibitor in there. So there are trials going on. A phase 3 trial just completed with olaparib in frontline castration-resistant disease, abiprednisone with or without olaparib, and then, and I'm sorry, I keep saying abi, but I mean abiraterone.
Yes.
Yeah. And then I'm doing a trial that is pre-selected, basically for patients who have BRCA1, BRCA2, or ATM, where we're randomizing them to either abiraterone, prednisone, olaparib, or combination. And this was stemming from an observation that I would encourage your audience to look into. This is a paper we published in Journal of Clinical Oncology in, I want to say, 2 years ago, where we looked at, it was a clinical trial that was all comers. And basically, we had the patients randomized to abiraterone, prednisone, with or without veliparib, which is another PARP inhibitor. And to our surprise, actually, we had a cohort of patients that we had extra tissue that we could look at, and it was part of the Stand Up to Cancer project. And interestingly, the patients who had DNA repair defects seemed to benefit from the treatment, irrespective of single agent or combination. And so that raised the question, and as you know, if you can get the same results with one drug, why do you need to put two together? Because, you know, there's toxicities and costs and so on.
Additional side effects.
That's exactly it. So that's the question we're asking. So I don't know. I think this is a bit early right now, but I think it's going to be interesting to see, you know, what the results look like and then go from there. But there are also other trials with other drugs, with olaparib and with rucaparib and other PARP inhibitors, looking at patients who have frontline metastatic hormone-sensitive disease without hormone therapy, looking at PSA patient relapse. There are plans for neoadjuvant type trials. So there's different kind of areas where people are looking at combination with radium, which would make sense.
Or immunotherapy for some mutation, maybe?
Yeah, so there is interest, especially where I would think in the CDK12 story, because immunotherapy seems to work. So adding PARP inhibitors. So there's different
combination.
Things
We are
going
still,
on. Yes.
Still looking
We're
for
still
the
very
best.
early in the we're very early in the field. Yeah.
Okay. Shall we train medical oncologists in genetic and genomics? So since we are entering this era now.
Well, I think you're just going to have to keep learning. You know, as much as possible, read articles, understand the pathway, and then work with individuals who actually, as I say, make their living out of doing genetics and genomics. I would say we have entered the era of genomics in not just in prostate, but certainly in bladder cancer and kidney cancer. And as we learn more and more about the profile, certainly different drugs are available in other cancers, and they're going to be moved into the, you know, into the prostate cancer, into the prostate or bladder or, you know, or renal cancer. So I do think that we as the GU oncologists, we sort of lagged behind because breast, ovarian was ahead of the game, lung was ahead of the game. Now we're catching up, and I think it's going to be an interesting learning experience.
All right. So what kind of advice you're willing to give a Moroccan oncologist, especially female, who are listening to you with great attention to what you are saying in this interview, and who regard you as a leader in this field and willing to follow your footsteps?
Thank you. Well, I'll tell you what I tell people. I would say hustle. Always remember, you are worth it, but you have to deliver. You can't expect to get benefits, but never deliver in there. And basically, don't delay your professional career. So whatever you decide you want to do, don't delay it, because the truth of it is you're competing with a lot of smart people, and a lot of smart, very qualified. And so parallel track your life, your personal life, your professional life, and be true to yourself. Whatever you're passionate about, do it. So I as I say to people, is because I was very passionate about multiple things in my life. I really wanted to have a family. but I also wanted to have a career, and I wanted to have an
Absolutely.
academic
You
career.
have to reconcile the two.
And I have been very fortunate to have a wonderful husband who has been incredibly supportive throughout my life. And the two of us actually worked very hard, both of us. So I got my first child, I was an intern, my first son.
Very hard.
And I got, first of my end of my first year, I delivered, and I actually never took time off. I took only 6 weeks maternity leave. That was it. That's what they gave us then. And was fortunate enough, I was able to work till the last minute. I got my daughter when I was in first year fellow. And I am really happy that I actually got my kids at that time. Yes, it was not easy,
Totally.
but it was very rewarding, because you feel like, you're a mother, you are a physician, you are a caregiver, you are, I'm saying all of these things. And it was very, very lovely from that perspective. So.
Maha Hussain, we would have loved to continue this interview a little bit longer, but we know you have a very
thank you very much.
Many things to do, and you have commitment to your patient, to your research. And it was a pleasure talking to you, and thanks for accepting our invitation.
Dr. Abu Fadl, thank you so much. It was my pleasure, and hopefully next time we'll be in person.
We hope to see you in Morocco with us in one of our masterclass. Inshallah.
Inshallah.
All the best. Wishing you all the best. Inshallah.
Thank you. Bye-bye.
You take care.
Bye-bye.